Good evening to you all. First of all, welcome to today's evening session. And as all of us are facing the health hazards with the pandemic and COVID-19 situation, all of us are struggling on a day-to-day basis. And I'm sure you're experiencing a lot of hardships on a day-to-day basis. But let me reassure you that we won't be in the hard times forever. We are seeing some significant improvements in the treatments coming up for COVID. So hopefully, very soon we would be able to conquer the disease and return to normalcy. So we are in different normalcy at the moment, and that is the reason we are conducting this awareness program digitally instead of going live personally. And we thought it's an opportunity to educate all our patients and all our population. And one of the importantly increasing incidence of diseases, which is inflammatory bowel disease. First of all, I would like to thank Click2Clinic, which is an excellent digital care platform offering online consultations and home care services, and they're doing a phenomenally good job in these difficult times. And I particularly congratulate Dr. Sujit, who is the founder of Click2Clinic organization, and Vivek and entire IT team for bringing up today's program and continuing to offer such kind of programs on a regular basis. I would also like to thank IMA North Hyderabad, which is I should say one of the most active IMA branches in the city of Hyderabad, and I'm fortunate to be one of the members of IMA North. So without further delay, we will move on to today's topic, that is inflammatory bowel disease. So let me cover the topics in few headings. What I would say is we'll try to cover with the introduction of inflammatory bowel disease, what is the importance of inflammatory bowel disease and why we should detect early, and how do we diagnose it, and what kind of treatment modalities are available, and is there anything new treatment modalities are coming up in inflammatory bowel disease. We'll also see that. And I'm going to talk on a different predictive model for treatment of inflammatory bowel disease, that is a KP3P model, which I'll explain more in detail. What are the complications of inflammatory bowel disease, and what are the surgical and also newer modalities of medical treatments available. So let's start with topic of what is inflammatory bowel disease. Inflammatory bowel disease includes commonly two conditions. One is ulcerative colitis, second is Crohn's disease. In both the conditions, the inflammation, which is nothing but swelling and ulceration of the mucosa of the gut lining, is a disease sign or symptom of inflammatory bowel disease. So that will lead to different clinical manifestations. So what happens in Crohn's disease is entire digestive tract or any part of the digestive tract can be affected, starting from mouth, esophagus, stomach, small intestine, and large intestine. In ulcerative colitis, the inflammation, which is swelling and ulceration of the mucosa, the lining of the gut, affects the large intestine particularly. There are other types of inflammatory bowel disease which are less in common, but let's today's focus on ulcerative colitis and Crohn's disease only. So why this condition is important? Why we should be talking about this disease? Well, 10 years before, we used to think that, or 20 years before, in fact, we used to think that inflammatory bowel disease will not exist in India. But with the change in lifestyles, change in geographies, transatlantic migration of the population, we are seeing increasing incidence of inflammatory bowel disease. And in fact, we should say that India is now probably seeing the highest rate of incidence of inflammatory bowel disease. That means the number of cases being diagnosed per annum are significantly higher than any other country across the world. In countries like USA, UK, and Australia, the disease is already affecting a lot of population, and India is rapidly catching up there. So this is the time we need to improve the awareness among clinicians and also common people about inflammatory bowel disease, how to diagnose and how to treat early and effectively. So in addition to a lot of other factors, the single most factor which is very important in the fact that why we should be diagnosing inflammatory bowel disease early is one reason, if you diagnose the condition early, a lot of complications can be prevented. A lot of people ask me whether it's a life-threatening condition. The answer is no. But if you delay in the diagnosis, it can lead to a lot of complications and impair the quality of life, especially Crohn's disease. For example, if we diagnose 100 people with Crohn's disease today, and theoretically, let's say we don't offer any treatment to these 100 patients, lock them up in the room and open the room 10 years down the line, for theoretical sake. So what happens to these 100 patients? Out of 100, 80% or 80 of the 100 people would have developed complications such as fistulas, strictures, perforations, and a lot of other conditions. But when we are locking these patients in the room, that means the 10 years before, at the time of diagnosis, 80% of the people would not have these complications. That means they will behave like an inflammatory condition. So when the condition is inflammatory, it is far easy to treat it. But when the condition has developed into complication like stricture, fistulas, perforation, it is very difficult to treat these patients in the condition. So that is the reason we should all be aware of this condition early and start the treatment at very early stage to prevent complications. How do we diagnose IBD? So there are various ways we can diagnose IBD. The first and foremost, whenever a patient reports certain symptoms, one should suspect inflammatory bowel disease. Let's look at both ulcerative colitis and Crohn's separately. Ulcerative colitis, as I said, is inflammation of the large intestine. So if somebody complains of long-standing diarrhea, loose motions or blood in the stool, mucus in the stool, a lot of times these patients are labeled as chronic amoebiasis. In fact, significant proportion of them would be suffering from chronic ulcerative colitis. So if somebody is having these symptoms, let's not ignore it. It's better to evaluate, investigate, diagnose the condition properly and start the treatment. Anybody has joint pains, unexplained joint pains. We are doing all sorts of bone x-rays, joint x-rays, but the disease is not getting diagnosed. We need to think out of the box and say, hang on, is this patient is having inflammatory bowel disease rather than a joint problem per se? That's another reason to suspect inflammatory bowel disease. If somebody is losing weight constantly, not putting on weight, that may be because of underlying inflammatory bowel disease. Same with Crohn's disease. Anybody, especially children, if they're diagnosed, and we are seeing a lot of Crohn's disease in children nowadays. If a child is failing to grow, if the child is not growing properly, not gaining weight, one reason may be inflammatory bowel disease, especially Crohn's disease. If somebody is having regular abdominal pain, vomitings, they may be because of Crohn's disease underlying. Somebody is having persistent vomiting, persistent diarrhea, loose motions, joint problems, eye problems, skin problems, may be because of underlying Crohn's disease. So anybody complaining of these clinical features, we should suspect inflammatory bowel disease and start to investigate. How do we investigate these patients? The most important test is colonoscopy. That is where we pass the camera from back passage. It goes into the large intestine in total. There where directly we see the lining of the intestine. So by doing colonoscopy, we can diagnose whether this patient is having a normal mucosa. Mucosa is nothing but the lining of the large intestine, or an abnormal mucosa. If we got abnormal mucosa, we normally take biopsies and test under microscope and then see any features of inflammatory bowel disease are present. That is a golden rule for diagnosing inflammatory bowel disease. But there are a lot of other tests we can do to diagnose or support the diagnosis of inflammatory bowel disease. First and foremost is simple blood test like complete blood picture. Complete blood picture may show low hemoglobin, raised white cell count, and raised platelets. We all get worried when the platelets get low, especially in viral season for the fear of dengue fever and other fevers. But if the platelets are very high, that may imply some underlying inflammation in the body. That could be because of inflammatory bowel disease. And when you look at inflammatory markers such as ESR and CRP, these can be very high. And that again supports the diagnosis of inflammatory bowel disease. They're not concluding test for saying inflammatory bowel disease, but they would support the diagnosis of inflammatory bowel disease. And then radiology. So when the patient is having these symptoms, we diagnose by colonoscopy, biopsy, and some blood tests. And sometimes we can also ask for CT scan of the tummy, CT scan of the abdomen, where we can look at small intestine and large intestine in detail. CT scan will again show any thickening of the small intestine lining or large intestine lining. And in case of Crohn's disease, the patient is having strictures. Strictures are nothing but blockages happening in the small intestine. And the oral contrast can tell us whether the patient has got blockage or not, or any fistulas are developing. So that is by contrast CT abdomen. And there are advanced investigations come up for IBD, which are CT enterography, CT enteroclysis, or MRI of the small bowel, which is called MR enterography or MR enteroclysis. So these are the radiological investigations to support inflammatory bowel disease. And these investigations play a part not only at the time of diagnosis, but once a diagnosis is made, to monitor the patient progress. Once in a while, we need to do these investigations. And based on the disease activity, we can modify the treatment. So these are the investigations which ought to be done on a regular basis. And after the radiology, we can sometimes think about capsule enteroscopy, where a patient swallows a capsule that goes into the small intestine and shows us a lot of ulceration. That can also be because of the Crohn's disease. And these are various ways of diagnosing inflammatory bowel disease. Now, there is a lot of confusion whenever somebody is diagnosed with inflammatory bowel disease, how to go about, how to start the treatment. There are a lot of medication available, but where to start, where to finish, and is everyone requires the same treatment, or is it different to different people? So a lot of confusion is around place. So in our clinical model, in place where I work, myself and my team, we designed a model called KP3P model, where a patient undergoes different steps in the evaluation and treatment. It's not only treatment, it involves lots of other modalities. So let's see the KP3P model. KP stands for Know Your Patient. So whenever somebody is diagnosed, I usually take a lot of details about the patient. What is the age of the patient, and what kind of history, any risk factors for this patient, any family history, any personal history risk factor like smoking, and what is the disease distribution, and anybody in the family has got any genetic factors are predisposing, any dietary factors are predisposed into development of inflammatory bowel disease. So all this will be documented. That is knowing the patient first. And then there are 3 P's we normally work on. So the first P is called prediction. So whenever any patient is diagnosed with inflammatory bowel disease, for example, if you take 2 patients, 2 different patients, not these 2 patients behave in the same way. One patient will have very quiet disease, may require only simple medication. Then other patient might require complex medication or running into complications. So why is it different? Why each patient is different? Well, that is because of a lot of genetic factors and how the body is made up. So there are certain risk factors for each patient. So whenever each patient is diagnosed with IBD, I usually score them based on the risk factors. For example, a young female diagnosed with Crohn's disease who has fistulas is at a higher risk of developing complications in the long term, in future. Whereas an older gentleman diagnosed with ulcerative colitis and doesn't have any other fistulas or any other complications of IBD is at a low risk of developing complications in the future. So these 2 patients would require different treatments. So that is called prediction. So we need to predict how each patient is going to behave in the next 5 years, 10 years, 20 years down the line. So based on the prediction, I would categorize these patients into low risk, medium risk, and high risk category. Once the categorization of this prediction is done, then we need to map their immunity. So again, this is a condition resulting because of abnormal immunity to the normal gut microbiota. For example, all of our intestines are full with filled with bacteria, viruses, and other things. So it is an abnormal immune response of our body to the normal intestinal bacteria and normal intestinal viruses, which can predispose to development of inflammatory bowel disease. In addition to that, there are genetic factors and there are environmental factors. For example, a lot of people who move to US, they can develop inflammatory bowel disease. Common. It's very, very common. That's transatlantic migration is one of the risk factors for developing inflammatory bowel disease. So whatever the reason, so once somebody develops, they got the disease. Now they certainly have some kind of altered immunity. So we need to map their immunity. For example, checking their status for hepatitis B, hepatitis C, HIV status, and what is their immunity for chicken pox. Are they already immune or not? Whether they already received all the childhood vaccinations, and all this immunity mapping will be done, and appropriate vaccination will be offered. So vaccination is one of the commonly ignored factor in inflammatory bowel disease, and only certain gastroenterologists with special interest in IBD are offering vaccination strategy. This is extremely important because once the disease is diagnosed in the next 5 to 10 years, the patients are at risk of developing various infections which are normally not seen. So that is the reason one has to improve their immunity and keep up with the vaccination. So yearly flu vaccine, pneumonia vaccine, MMR vaccine, and chickenpox vaccine if they're not already immune, all these need to be started. So that is what we call the second P model. And then once the patients are up to date with their immunity, then we start the medication and then monitor the side effects of the medication. That is the final P. So that's the 3P model. So what are all the different medications available for treatment of ulcerative colitis and Crohn's disease? Commonly speaking, there are only 5 to 6 categories. The commonest agents are what we call 5-ASA compounds. So some of you might have been on compounds such as mesacol, vegazodi, and other agents. So these are called 5-ASA agents, 5-amino salicylic acid agents. Those are the common agents. The next category is called immunomodulators such as azathioprine, 6-mercaptopurine, or methotrexate. The next category is biologic injections such as infliximab and adalimumab. Now, last week in India, we have another molecule introduced called vedolizumab, which is again a very promising modality of treatment for a lot of IBD patients. In addition to these, we also got steroids. So steroids are excellent drugs in the short term. If somebody has got very bad symptoms, we can start the steroid medication, and that should quickly reverse the symptoms. But these are not a good choice of treatment for long-term medication. So anybody requiring more than 2 courses of steroids in a year, we should immediately switch over to immunomodulators or biologic injections. The next category of injections are biologic injections. There are 2 types of injections available in the market until last month, like adalimumab and infliximab. Infliximab is given in the form of intravenous infusion, like you have saline infusion. Adalimumab injection is like insulin injection. One has to inject underneath the skin. How long we need to treat this medication with? So nobody knows. So usually in my practice, I advise patients to stick on to 1 year of treatment at least. As soon as the disease is under control, we can stop the biologic injections and continue with immunomodulation with methotrexate or azathioprine, for example. Now, in the last month, another new molecule, as I said, vedolizumab has been introduced, which is a very promising agent, and it is special in the sense that it is gut selective. That means it acts only on the intestine, whereas other biologics acts on the entire body, whereas vedolizumab acts only on the intestine. Thereby, other complications like tuberculosis and other chest infections are prevented. So this is a promising agent, and now we can access that in India as well. And in addition to that, sometimes we have other supplemental medication like antibiotics, which can be used for short-term treatment. We also got turmeric products called curcumin. So curcumin, our ancient people used to use it a lot, the turmeric, and which is modified by chemical formulation and now comes in the form of capsule. So this is supposed to improve the immunity and supposed to help patient with ulcerative colitis, not particularly so with Crohn's disease. Now, a lot of patients ask me when we start this medication, is my immunity going to be down with this medication? The answer is yes, there may be a possibility some of the immune mechanisms can be modified. So it is slightly at risk of developing other opportunistic infections, but they're wonderful medication. They can control the disease very, very quickly. And if we adopt this model, the prediction model and immunization model, regular monitoring, a lot of these complications can be prevented. And a lot of medications are absolutely going to be safe. There are different monitoring methods for each of these medication. For example, azathioprine, we need to monitor complete blood count once in a week in the first 1-2 months, then once in fortnight, then once in a month or once in 3 months. So as long as we are sticking to the rules of monitoring this medication, the chance of having complications are very, very minimal. Same with biologic injections. A lot of people get scared when I say biologic injections. But trust me, there are excellent medication available. And the sooner we start these medication, the effect will be better. A lot of complications can be prevented. And again, as long as we follow the rules, predicting the risks, immunizing before starting the biologics, checking for underlying tuberculosis, and correcting all these factors, these are wonderful medication. And what is the role of surgery? So, for ulcerative colitis, surgery by removing entire large intestine can be curative. But we offer that only if the patients are not responding to any of the medication and getting into some other complications. Then we have to offer surgery where the large intestine can entirely be removed. So potentially that is a cure of ulcerative colitis. But again, it's not a simple surgery. It has got its own complication risks and other things. What about Crohn's? Well, Crohn's can affect any part of the digestive tract. So surgery is not a cure, but surgery is offered to Crohn's patients only if there is any complication, such as blockage is happening, a perforation is happening, or abscess formation is happening. Then only we offer surgery for Crohn's patients. And in addition to this, there are a lot of other newer medication in the pipeline. A lot of research has been going on, but we are still yet to see a lot of new molecules hitting the market. So it is going to be some time. Right now, there are lots of trials going on, and one of the trial is called filgotinib trial. Some of my patients are already on the filgotinib trial, and this is a promising agent again. But still, right now it is in the trial phase. And once again, when I say trial, a lot of people get shocked about trials. But if you look at how the medicines are developed, even the paracetamol has to be developed through a trial. That means a significant number of patients will be given a medication. There are other group of medication who are not given the medication. You are given dummy medication. So at the end of the trial period, two medications are compared and then see whether this effect of medication is truly beneficial or not. So that is how the clinical trials are conducted. Yes, sometimes there can be side effects with the medication and all, but every medication has got side effects, so not to get worried about it too much. And so once we start this medication, any suitable medication, choose this medication, and then there are two approaches in treating using this medication. One is called top-down approach, where we initially use very powerful medication like biologics, and once the disease control is achieved, we cut down to azathioprine or 5-aminosalicylic acids. That is called top-down treatment. Second is step-up strategy. We start slow, start with the simpler agents, and gradually increase the complexity of the medication. So I need to choose my medication based on your risk profile, based on the immunity status, based on the potential complications, and which agent to be chosen, how to start it, whether to start with top-down therapy or step-up therapy. So all these need to be addressed. And once I start the medication, then I need to follow these patients on a regular basis to look for any complications of the medication or I mean to say side effects or any complications of the disease. As I said, IBD can also affect other organs such as eyes can go red, mucosa, oral ulcers can be formed, bones can be affected, osteoporosis can be there, liver can be affected, skin can be affected. So again, we need to monitor for any of these complications very, very closely And anybody developing these complications, we need to address them appropriately. But the good thing about IBD is 80% of the patients, if you adopt to a scientifically proven model, 80% of the patients do very well with simple medication and all. But on the other hand, if you miss the boat early, if you miss the diagnosis, don't start the medication appropriately in early phases, the complications can be quite significant. They can impair the quality of life, make the daily life miserable. But my dear friends, anybody having these suspected symptoms, please report to your nearest gastroenterologist early so that investigations can be done appropriately, diagnosis can be done appropriately, and the right treatment for right patients can be started in right time. With that, I will stop my talk and I will take any questions. Okay, one question we have is, will it affect my children? And this again very common question. So I would say that if somebody is having IBD, the chance of children getting affected is very small, so not to get worried about it. But if both husband and wife, both the parents are having IBD, the chance of a child getting IBD is quite significant. So not to worry about it, that can be dealt with accordingly. And the other question is, somebody is saying again, chronic diarrhea is happening and I'm not getting better. So that needs to be investigated in the form of colonoscopy and other blood tests. Okay, one great question is how to prevent future generations. Well, there is nothing to prevent future generations having getting IBD, but as I said, early suspicion and early appropriate investigations is the key. But there are couple of scientifically proven methods. When a child is born, children having breastfeeding are supposed to develop some kind of immunity towards IBD than people who are not being breastfed. And excess antibiotic usage is also not good in childhood. That is also should be avoided. But otherwise, there is no golden rule, golden standard to say that you do this thing and IBD can be prevented. But early suspicion and early investigations and starting the treatment early is very important. Um, are there any worrying symptoms to address immediately? Well, anybody with passing motion more than 6 times with lot of blood, weight loss, and vomitings, these need to be reported to your doctor urgently. The reason for that is IBD, as I said, can lead to lots of other complications such as skin involvement, liver involvement, and other things. But it can also lead to cancer sometimes. So, especially ulcerative colitis, when it affects somebody for more than 10 years, there is always a small risk of developing colon cancer. Large intestine cancer can be a risk factor. So we need to, that is the reason we need to follow these patients very, very closely, and so that no other complications would be developing. The other question is, can we say IBD is a lifestyle disorder? I wouldn't say it's a lifestyle disorder as obesity and diabetes. It is a combination of multiple factors. One thing is the lifestyle, which is irregular diet, irregular food, and lots of westernized food. These are there to play a role, but that's not the only reason. It's a combination of factors like lifestyle changes, genetic factors, and immunity, infections. Lots of combination of factors. So not one single factor. That's the reason we can't say it's a lifestyle disorder. Other question is, can fasting help Crohn's disease? Again, the answer is there is no scientifically proven reason why fasting should be helping Crohn's disease. And in fact, I would not suggest fasting at all because most of the patients with Crohn's disease are at a risk of developing malnutrition. The nutrients will not be absorbed appropriately. On top of that, if you go on fasting, one will lose a lot of nutrition and that can predispose to a lot of other complications. One more question is, I have a pregnancy and can we plan normal, can we expect normal pregnancy outcome if I have IBD? So I will split this question into two parts. One, somebody might be asking, I already got IBD, can I plan pregnancy? The answer is absolutely fine. And a lot of medication which are used for IBD treatment are safe for using in pregnant women. Only thing is, during pregnancy we should not be letting the disease control go away. If the disease is flaring up during pregnancy, there is a chance of miscarriages happening. So if you adequately control the disease activity during pregnancy, and there is almost guaranteed that one will succeed with normal pregnancy. Okay. Other question is, can we travel with IBD? The answer is perfectly yes, but you need to take all the precautions and especially vaccinations and other things. Of course, we are not traveling nowadays because of the COVID, but once everything is resumed to normalcy, one should be able to move around perfectly well without any major issues, provided certain precautions are taken and vaccination is taken and stick to normal diet, healthy diet, that should be fine. The other question is, what about my diet and IBD? That's again a very commonly asked question. So a lot of people will advise you to avoid that, avoid this, and avoid milk and other things. But if you look at the scientific data, scientific evidence, there is only one reason, one answer. If certain food is upsetting your tummy, and say for example, if you eat an apple, for example, that has upset your tummy, so you need to analyze what you have eaten today, and you come to conclusion that, yeah, I have eaten apple. It may be the cause of that, so we should avoid. We should try next time. Second time also it is happening in the same way. We should avoid third time. So this is called elimination strategy. Apart from that, there is no hard and fast rule say that you need to avoid this, you need to avoid that. So you need to try and test different diets and then stick to whatever suits you best. Otherwise, if you keep on avoiding, a lot of things will be eliminated, and you won't be adequately replaced with a lot of vitamins and minerals. There is nothing like a best diet. So somebody is asking what is the best diet for Crohn's disease. As I said, uh, any good, healthy, balanced diet is good. So the common problem is a lot of people start to avoid a lot of food items and all. That should be banned from practice. So everybody should be trying different diet and see which one suits them best. If something is upsetting, that should be avoided. Somebody is saying, what is the common reason for diarrhea for 6 months? Well, that could be various reasons. It could be as simple as thyroid problem, for example, that can cause diarrhea, or chronic infections can cause diarrhea, IBD can cause diarrhea, or another condition is called IBS. Inflammatory bowel disease is different, irritable bowel syndrome is different. That is called IBS. IBS can also be cause of chronic diarrhea, but that can be diagnosed only after investigations. So if somebody got chronic diarrhea, that has to be investigated, and rarely, not to scare anyone, but um, colon cancers can also cause diarrhea, chronic diarrhea. So that has to be investigated. If anybody is having more than 3 months of diarrhea, that has to be investigated. Another question is stress, whether it can increase IBD symptoms. Definitely yes. So all IBD patients will have a component of IBS, that is irritable bowel syndrome. So any stress can aggravate the IBS component of um, uh, inflammatory bowel disease. So answer is, anybody with stress can aggravate symptoms. So we need to optimize the lifestyle, optimize stress factor, and then the symptoms can be minimized up to a certain extent. Well, somebody is asking my contact details, and I would say this is not the platform for that, but you can go to my website called www.drkiranpeddi, drkiranpeddi, kiranpeddi.com. So where you get all my details, and then my contact number will also be there. Or if you can't get hold of, you can call my secretary 9390150150. 9390150150. I'm happy to help with whatever the limitations happening at this stage. Another very good question. Somebody asking, can Crohn's disease increase the risk of colon cancer? Now, as I said, Crohn's disease can affect small intestine and large intestine. If it is affecting large intestine, technically the cancer risk is not as high as ulcerative colitis, but if the large intestine is inflamed over a period of many years, by whatever reason, whether it's Crohn's or ulcerative colitis, yes, there is always a small risk of developing colon cancer. That is the reason every patient with IBD has to be under regular follow-up with their own gastroenterologist nearby. Somebody is asking IBS and IBD are the same symptoms. Some of the symptoms do overlap. So there is again, the name also is a bit confusing, IBS and IBD, but both the conditions are completely different. IBS is irritable bowel syndrome where there is no disease as such, but IBD is a specific disease we are tackling with. And in IBS, if we investigate colonoscopy, CT scan, blood test, everything will come back as normal. But the intestines are sensitive. That is the reason people develop diarrhea and other symptoms. Whereas in Crohn's disease or IBD, there is an underlying disease. That is the reason people don't develop symptoms. Is long-term diarrhea a symptom of colon cancer? So again, I don't want anybody to get panicky on that, but if somebody is developing change in bowel pattern, for example, you normally have a very regular bowel pattern, you go to the toilet once a day, suddenly overnight it changes and you don't go get into complete constipation, or you develop completely significant diarrhea. So that is called change in the bowel pattern. That could be an indicator of underlying colon cancer, but it may be because of all other conditions also. The bottom line is anybody with these symptoms need to be investigated without getting worried. That is the crux of it. Well, somebody is saying, I'm worried about the immunomodulators and biological powerful injections and all. Now, as I said, if you stick to the protocol of evaluating the immunity status, immunity the possible risk factors, and going for regular immunization, the chance of developing complications with the medication is extremely small. And to be honest, I got a lot of IBD patients who come across India to see me, and touch wood, so far no major complications happened to any of my patients. That just because of the special um, protocol we follow, and this is a condition where it requires a lot of patients from your doctor and a lot of patients from your side as well. So both of us require a lot of patience and need to spend time, understand the disease, start the treatment, and monitor to any complications. If that can be done, not to worry about any complications happening. Is swelling of face and feet a symptom of Crohn's disease? That's another question. Well, it is directly not a symptom of Crohn's disease, but what happens with Crohn's patients is the albumin will be low because of the poor nutrition, not able to eat well, the protein level will go down, and the albumin low will result in fluid accumulation with the swelling of feet, swelling of thighs, legs, and face as well. But there are a lot of other conditions which also need to be evaluated. Anybody developing with swelling need to be evaluated for nephrotic syndrome, for example, or like patient may be losing protein in the urine, or maybe because of a heart problem. Heart failure can also result in fluid overload. So there are a lot of again reasons why somebody can develop swelling of the face and swelling of the legs and all. Well, when one very relevant question: what complications can occur due to ulcerative colitis if left untreated or not given proper medication? And this is more practical question, I would say. What happens is, as I said, if you don't treat any of these patients and then just leave them alone over a period of time, the inflammation continues to be growing without any control, and that can lead to local complications and systemic complications. What are the local complications? Within the colon itself, it can lead to cancer, it can lead to strictures for Crohn's disease like blockages and all, and a lot of other complications like fistulas and all with Crohn's disease. Systemic complications, as I said, eyes can get affected, liver can get affected, and skin can get affected. Blood vessels can get affected. People can get DVTs, deep vein thrombosis, means clots in the blood vessels, and a lot of clots in the lungs. And nutrition can go down, and quality of life will be miserable. So you won't feel like going out, you won't feel like going to work, you won't feel like spending with the family. So a lot of quality of issues, quality of life will go down, in addition to the actual complications of the disease. Well, that is one more interesting question. Do we all get permanent cure in coming days? No one knows his answer because till now there is no cure for inflammatory bowel disease. But the way I look at it is there any cure for high blood pressure? Is there any cure for diabetes? The answer is no. So if you look at diabetes patients and high blood pressure patients, they have to take medications for long period of times, lifelong. So similarly, IBD patients and has to take medication over a period of time, and at least some proportion of IBD patient will go into what we call remission, means the disease becomes completely inactive. So once the disease goes to completely inactive stage, the medication can be brought down to simple and minimum dose of medication. Okay, so there are again more number of questions flowing around, but I'm afraid we're already 15 minutes post. But I'll take one more last question before we close it. Somebody says, as per my ultrasound report, no bowel thickening is seen. Does this indicate there is no? Does this indicate colon cancer? Well, first of all, ultrasound is not the best test to look for bowel. Intestines are not seen very well with ultrasound. So based on the ultrasound finding, we should not conclude anything about the intestines. And if you want to conclude something about the intestine, that has to be a colonoscopy or a CT scan, not an ultrasound scan. So I would say ultrasound is not a very good useful test. What do you mean by simple medication? So simplest medication of all this is the 5-ASA compounds like mesacol, Vegazodi, or Cool Gut. All these medication are there. Those are the simplest medication for IBD patients. Now, the complex medications are azathioprine, biologic injections, and all those are complex medication. Somebody is asking, is there eating rice is the reason for developing the disease? The answer is no. Eating rice is not a reason to develop IBD. So in other words, there is nothing you could have done to prevent developing IBD. It's not in your hands and not in anyone's hands. So please don't feel guilty for doing something that might have developed into IBD. A lot of patients I get, they say, I was eating irregularly over a period of time. I was binge eating. I was taking that and this. So the bottom line is there are certain risk factors, but none of them would conclude saying that this is the reason you probably developed IBD. So don't blame yourself and enjoy your disease in a way. I'm telling frankly, because this is the disease which is not going to go away. So you have to adjust your medication and start to lead normally. Get a good gastroenterologist nearby. You can focus on your disease and treat appropriately. Will show sympathy to your symptoms, and they got a support structures. All these need to be taken care. So with that, I once again thank Click2Clinic team, entire team worked very hard to bring this session today, and also the entire team of IMA North Indian Medical Association North Branch of Hyderabad. Thank you very much for supporting this activity. And then with that, I would take leave today. Thank you.